Good morning, everyone. We're going to go ahead and get started. Thank you for joining this morning. My name is Michelle Mickus. I'm a hospice and palliative care pharmacist and the Vice President of Pharmacy Services at Delta Care RX, which is in Pittsburgh, Pennsylvania. And today, this morning, we're going to spend some time together going over an update in pain management with a palliative care focus. I do not have any financial disclosures to disclose. And before we really dive into the presentation, I just want to kind of put into context what we're going to be going over today. So pain is one of the primary reasons that patients of all stages in their health journeys, whether they're seriously ill, terminally ill, or not terminally ill, it's one of the main reasons that patients do go to their primary care providers. In general, it is largely undertreated. Patients feel the same, and providers don't feel confident in treating it. Approximately 80% of patients that do visit their PCP report pain during visits, and ultimately pain affects everyone. As kind of a roadmap for our discussion today, we do have 5 objectives. The first is to review the definition, etiology, and prevalence of pain. The second is to examine the WHO pain ladder and other treatment guidelines briefly. We will discuss non-opioid pharmacologic interventions. We'll move into opioid pharmacologic interventions, and then we'll close with some identifying and applying the pharmacist's role in pain management. So we'll kick it off here with background. So review the definition, etiology, and prevalence of pain. So I'd like everybody to take just a brief second and answer the question, how would you define pain? So you don't need to put anything in the chat, just think about it yourself. How would you define pain? Okay, so some people, when I am in a real setting giving this presentation, I inevitably have a couple people that do shout out an answer, which I love. And some of those answers in the past have been, oh, the worst pain I've ever been in my life was when I fell off my bike and broke my entire leg in 6 places. I've had childbirth be told to me. Recently, I had a colleague actually mention that during IDTs, they said they asked the group to describe pain, or I'm sorry, the patient and caregiver to describe the pain. And the response was, how would you describe love or heartbreak? Not everybody has the words. And that came to me with the context that pain in the setting of a serious illness is very complex, and it's also very humbling. So some people may, you may, all the audience members, some of you may have thought of a personal experience or an experience, whether it happened to you or whether it was to a child or a family member that you saw that was terminally ill. Some of you may have thought of a patient experience that you saw during rounds or a particularly difficult case if you were involved with pain management for a patient that was just very hard physically and emotionally to get the patient comfortable. And some of you may have defaulted to what you've read in literature, what you think the quote unquote official answer of the definition of pain would be. Fortunately, the International Association for the Study of Pain in 1979 offered an explanation that we now use to ultimately describe pain. And I am going to read this to you: an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So there's 2 things I really like about this definition, and admittedly, lots of people like about it. It can be sensory and emotional. It is an experience that can be of either origin. And it can also be on actual or potential damage issue or described in terms of such damage. So those are all very important things. And as we move forward with our presentation, that really is going to be the pathway for how we identify that there is not always going to be a one-size-fits-all approach. And just because one thing works for one patient doesn't mean even in a similar situation, it would work for another patient. Pain is ultimately a very personal experience. So there are some definitions we have to establish. So a little bit of vocabulary here. First is the term allodynia. So this is pain due to a stimulus that doesn't normally provoke pain. So it would be atypical if you were putting a jacket on this morning for if the zipper grazed your arm for that to induce a painful reaction. So this you can think of in terms of a lower threshold for pain. So something that is not normally painfully stimulating results in pain. Second, and in contrast, is hyperalgesia. So this is increased pain from a stimulus that does normally provoke pain. So it's normal for if you prick your finger for that to cause pain. Okay, that's certainly not a pleasant experience by any means, but it would be atypical for somebody to describe that pain or rate that pain as a 7 out of 10, or for them to verbalize that it was excruciating or extremely painful. So this is an increased response to pain. Side note on hyperalgesia, this can also be part of a disease process. So there are patients that we will, in kind of extreme complex cases, we will determine that they could potentially be experiencing hyperalgesia. That happens more common and more often than allodynia. Okay, next is chronic pain. This is pain that extends beyond the period of tissue healing. So when the tissue itself has actually healed, but the patient is still in pain, or with low levels of identified pathology that are insufficient to explain why the patient is still experiencing the level of pain they're experiencing. Now, in contrast to chronic pain, we have acute pain. Acute pain can turn into chronic pain, just as a side note, but acute pain is defined as pain that begins suddenly. It's usually sharp in quality. It can be mild and just last a minute, like if you twist your ankle and you just need to walk it off, or it could be severe and last for weeks or months. In most cases, it does not last longer than 6 months, and it goes away when the underlying cause of the pain has been treated or has been healed. So we've all experienced acute pain before. Nociceptive pain is pain that arises from actual or threatened tissue damage to non-neural tissue and is due to the activation of nociceptors. So this can be somatic or visceral. So sometimes I'll describe nociceptive pain as pain from a punch. If you get injured, that is nociceptive pain. And specifically, that's somatic pain, and that is more common. Visceral pain is like organ pain related. So like I've had people say to me before, my kidneys hurt. You might think to yourself, how do you know your kidneys hurt? That can actually be an experience of visceral pain. So examples of that would be inflammation. But of course, then somatic nociceptive pain would be sprains, fractures, etc. So this is in contrast to neuropathic pain. Neuropathic pain is pain that's caused by a lesion or disease of the somatosensory nervous system, and it can be of central or peripheral origin. So post-herpetic neuralgia, diabetic neuropathy, trigeminal neuralgia, these are all descriptions of neuropathic pain. And that term description is important because neuropathic pain is a clinical description. It is not a diagnosis. All right, in addition to some of that vocabulary, we need to understand the etiology of pain. So there's many different etiologies of pain, and these are the ones that we're most commonly seeing. Biomechanical, so somebody slouches at a desk all day or routinely is doing the same patterns, like think of a baseball player. Biomechanical would be a shoulder pain that they may experience. Mechanical pain can result from sprains, fractures, or structural problems. A neurological would be, again, diabetes, shingles, tumors, pressing against neurons, or even medications, especially chemotherapy can cause neurological pain. Non-mechanical pain would be infections, neoplasm, atherosclerosis. And then lastly, psychological pain too. So remember, when you were thinking about pain in the very beginning, some of you may have experienced pain of a heartache or from the loss of a loved one. That is very much an etiology of pain also, and it's psychological. This can also be compounded with anxiety, depression, and stress can make that worse. So some of the numbers corresponding with pain and why it's important that we're having this presentation today. So 50 million Americans suffer from significant or chronic or severe pain. 25 million of those, so half of those experience daily chronic pain. They report experience daily chronic pain. And 23 million, so the other half, do report severe pain. There could be some overlap there though, so that's not the whole 50 million people experience one of those two. Some of the people that are experiencing daily chronic pain could have identified that pain as severe. Nearly half of all respondents reported that that did report the most severe pain still said that they categorized themselves as overall healthy. Their overall health was good or better. So that is important. All of us at some point are, again, going to experience, we have experienced pain, but even patients that are reporting pain are still saying that they are healthy individuals. 1 in 10 people are reporting chronic pain. So women are 2 times more likely to report chronic pain than men. And patients that are greater than 40 years old are 2 times more likely to report pain than patients that are younger than 40. Cultural differences also do contribute to reports of chronic pain. Some cultures identify pain as a sign of weakness, and therefore it really takes a lot for them to express it, or they just don't ever express pain, even though you can verbally express pain, even though a lot of times the signs and symptoms of pain can very much be visual. The Journal of Pain and Symptom Management in 2016 said that during anti-cancer treatment, so mainly chemotherapy as well as radiation, 55% of cancer patients will experience pain. After that curative treatment, still roughly 40% will experience and report pain. And patients that have advanced metastatic or terminal diseases, the terminal oncology patients will report 66.4% of those patients will report pain. Pain on a scale of 1 to 10 was reported as greater than 5 by nearly 38% of all patients. So over a third of them are reporting pain greater than 5. At specifically end of life, so the last 6 months of life, up to 75% of hospice patients with cardiovascular disease will report pain. I include this because a lot of times we associate pain with cancer pain, and that's not always, pain is not exclusive at end of life to cancer diagnoses. Patients with all serious and terminal illnesses can and do report pain. Roughly 50% of patients with AIDS report pain. That increases to 93% in an inpatient setting. And in patients with dementia, since a lot of times they're actually unable to verbalize their degree or extent of pain or type of pain, not in just dementia patients, but also in any neurologic disease, think ALS, MS, they may be able to, or were unable to quantify it for that reason. Okay, so for methods, we're going to examine the WHO pain ladder and other treatment guidelines. This is one of my favorite things to talk about. So how are we going to do what we say we're going to do? So this is the very simple picture of the WHO pain ladder. This has not been updated since 1986, which means we have been using this pain ladder for 35 years now. And there's been some groups call into question if this is so relevant, and we're going to go over that in a moment. But this is probably, the WHO pain ladder is definitely something you've seen in pharmacy school books before, and probably since pharmacy school also you have seen this ladder. And it's 3 steps the way it stands right now. Start here, and as the pain increases, or the relief decreases, you just advance from one step to another. The WHO pain ladder was designed for cancer patients. Again, in 1986, the World Health Organization presented this analgesic ladder and really said this is going to be the framework that physicians can use to develop treatment plans for cancer pain. So this really paved the way for considerable improvements in the management of cancer pain, and it's come a long way since 1986. So this simple example that I'm showing right now has actually been translated into 22 different languages. And it's also served as the catalyst for increasing awareness, not just in the US, but around the world, of the importance of treating pain in cancer patients. So it's removed some of the stigma around patients that are on pain management regimens. This also helped legitimize the use of opioids, importantly, for treatment of cancer pain, and it encouraged numerous worldwide teaching campaigns on the use, benefits, and side effects of narcotics for the treatment of pain. So again, removing that stigma. Okay, so I mentioned that some people have called into question the relevance of the WHO pain ladder, since it is 35 years old now. So it outdates a number of participants today. The cornerstone of the WHO pain ladder really, though, rests on 5 simple recommendations for the correct use of analgesics, something that pharmacists are perfect to counsel and educate patients and other members of the disciplinary team on. So this advice is super applicable still today, and it's not only for cancer patients with pain, but also for all patients with either acute or chronic pain if they are requiring analgesics. So pharmacologic intervention. So there are really five tenets that it rests on. The first is oral administration of analgesics. So there's a rule of thumb in medicine, I'm sure we're all aware of it. If the gut is functioning, use it. So if and whenever possible, we do want to administer analgesics orally. Two, analgesics should be given at regular intervals. So my husband will joke with me and just he says all the time, we don't chase pain, we treat pain, because I used to say that frequently, that we don't want to wait until a patient's in pain or has an unacceptable level of pain to attempt to manage it. So we need to get it under control and then keep it under control. And we do that by giving analgesics at regular intervals as needed and adjusting ongoing. Three, analgesics should be prescribed according to pain intensity and evaluated by a scale of intensity of pain. We're going to go over this as we go through the steps and go through the drugs that are used at the different steps. Four, the dosing of pain medication should be adapted to the individual. So another thing some of my colleagues like to joke with me about is I often will say that pain management is as much of an art as it is a science. But it is true. We need to make sure that we are focusing on the patient and we're making our decisions with them at the center of everything we discuss. And then lastly, analgesics should be prescribed with a constant concern for detail. So the takeaway here really is that the detail, yes, we need to worry as healthcare providers about the nitty-gritty details, but we also need to remember that the level of detail cannot be overwhelming to the patients and their caregivers that are ultimately going to have to play out with the regimen that's decided upon. We need to meet the patients and caregivers where they are with their level of understanding. This is not your pain regimen. It's not my pain regimen. When we are working on patients and working up pain regimens, it is their regimen, and we need to make sure they fully understand it. So therefore it can be used appropriately, hopefully be effective, and most importantly, be used safely and improve outcomes. There are some other treatment guidelines. We're not going to go over them in depth because the WHO pain ladder is the standard of practice right now, and we just went over its relevance still. But the American Academy of Pain Medicine, Pain Society, the CDC, as well as the International Association for the Study of Pain, and the Academy for Integrated Pain Management all do still have their own treatment guidelines. You are welcome to look them up yourself, but just a little spoiler alert, they all really follow the same structure as the WHO pain guideline. So I like to kind of think that they white labeled them and maybe added some things and made it a more robust ladder than the WHO pain ladder, but it all follows the same stepwise approach to pain management. This is the first of a couple times you're going to see this slide because this is the most important slide in here. Pain management rights. So these are rights that your patient has. They deserve the right drug, the right dose, the right route of administration, and at the right time. So we're going to talk a lot about half-lives, dosing schedules, long-acting formulations, short-acting formulations, what can be crushed, what's available as a liquid. And this slideshow really will be a good reference for you to look back on. Also keeping in mind, just because something is on the market doesn't mean it's always currently available in the marketplace. So we do need to make sure that we are always, your patients deserve and have the right to these four things. All right, we will get into our discussion on non-opioids. So we're going to discuss non-opioid pharmacologic interventions, and this comes into play on step 1 of the WHO pain ladder. So step 1 is non-opioids with or without an adjuvant in managing pain. So non-opioids generally fall into 3 categories: NSAIDs and aspirin. Sometimes we group those into one category, but NSAIDs, aspirin, acetaminophen, and then other. So a catch-all category of other. So most of us are probably very familiar with these OTC, largely OTC products: NSAIDs, aspirin, and acetaminophen. They inhibit the COX pathways. Acetaminophen, of course, does not have any antiplatelet activity, so it's safer in our cardiac patients. Acetaminophen also does not have anti-inflammatory activity. So if you think that pain is arising from some inflammation, acetaminophen is not going to be the go-to. NSAIDs and aspirin, we need to be concerned with GI distress or a history of GI involved side effects. They may not, again, be appropriate for cardiac patients, and we do need to use them in caution with renally impaired patients, though that's generally very renally impaired patients, or if we plan on having patients on these drugs for an extended period of time. Acetaminophen is hepatic toxic. Be careful. It's in everything OTC. This group of people knows that more than most people. There's not much literature surrounding the max dosage limits, but it is generally understood that we should not be exceeding 4 grams of acetaminophen a day. I always say in the population I work with, which is the terminally ill, 3 grams a day, that is the geriatric guideline. But even if it's a 55-year-old that's on service with hospice, we still will consider 3 grams as the upper limit of what they should be on. And we'll always just say that's 9 of the 325 milligram tablets is what we end up telling them, because they don't understand milligrams to grams. And we really do drive home that, if you come down with a cold and you want to, you think you're going to just, take something over the counter, you have some Dayquil or NyQuil in your cupboard, to please let us know, or call your local pharmacist to verify, because if there's acetaminophen in there, it could be compounding a lot of the drugs that also have acetaminophen in it, which may be part of their pain regimen already. Gabapentin is a non-opioid that we are going to have in our other category. So gabapentin is used for hyperalgesia and neuropathic pain. It is renally cleared, which means in our patients with CKD2 or more severe in our end-stage renal disease patients, we need to make sure that we're dosing it at the appropriate frequency, which is sometimes twice a day, more commonly once a day, and that we're not really pushing doses very rapidly. It has moderate oral bioavailability, 40 to 60%. The half-life in a normally in a normal renal function patient is roughly 5 to 7 hours, but it can be up to 56 hours if the creatinine clearance is less than 30. So again, this is something, if I had to pick one drug that I'm constantly renally dosing, it is this drug for our hospice patients. It's widely distributed in the CNS. Because of this, we know that there is a little bit of street value associated with gabapentin. I know this is just Pennsylvania practitioners, but we're not that far from Virginia. It's a controlled substance in Virginia. So some states have gone that far. The max daily dose is dependent on indication. So it's 3,600 milligrams a day in the literature for seizure activity, but for pain, it's actually listed as 1,800 milligrams. That being said, there's definitely been patients we've had on higher. It's just increased doses beyond 1,800 milligrams don't always have predictable increases in relief from pain. Pregabalin, a brand name Lyrica, is 3 to 10 times more potent than gabapentin. It is a controlled substance. Keep that in mind. It also has the same indications, hyperalgesia and neuropathic pain. It's also renally cleared. Very good oral bioavailability, and the half-life of caps in solution is 6 hours, which is good because this is most often actually not dosed 4 times a day. Most often it's dosed twice a day or 3 times a day. Max daily dose is again dependent on indication, and it's a range of 300 to 600 milligrams a day. But again, that's not to exceed. There can be adequate relief obtained at doses much lower than that. Tricyclic, so here we'll talk about amitriptyline, doxepin, and nortriptyline. Abrupt discontinuation is a contraindication. So these drugs can result in anticholinergic rebound because they do have anticholinergic side effects. So there are cardiac implications also, specifically if they're on many other drugs that have cardiac implications, such as QT prolongation. Confusion and sedation is a side effect, which in our population, or in the geriatric population or the seriously ill population that may struggle with activities of daily living, does increase their fall risk. There is a documented warning for serotonin syndrome. Admittedly, it's rare, but you need to be aware of that. And weight gain is one of the biggest side effects and why we don't see TCAs that often. Plus, there are just better options out there now, specifically in terms of antidepressants. That being said, when patients do come to you, if they're using TCAs for pain relief, specifically neuropathic pain relief, nortriptyline or Pamelor is the preferred TCA. It is the least anticholinergic, and Elavil, which is amitriptyline, is the most anticholinergic. So you will see more side effects with amitriptyline than you will with nortriptyline. SNRIs, so venlafaxine, desvenlafaxine, and duloxetine. Another contraindication for abrupt discontinuation, this one's because of withdrawal. Effexor, venlafaxine, and desvenlafaxine can increase hypertension. We would never initiate this in somebody that has a history of hypertension. Liver impairment's a contraindication for duloxetine or Cymbalta. We're seeing lots of both things, lots of liver impairment and lots of more prescriptions for duloxetine since it's been generic for some time now, multiple years. The cost has gone down significantly on it, and prescribers really are choosing to use it for kind of total pain relief, which is a little bit beyond the scope of this discussion, but there's a concept of total pain or whole pain, and duloxetine tends to be good for that because of its neurologic implications. Again, a rare warning, but serotonin syndrome could result, and weight loss is a side effect of SNRIs. That's important to be aware of because in patients with waning appetites as they approach end of life, or if they already are on other drugs or chemotherapy that's reducing their appetite, then these are drugs we may want to avoid. Steroids such as prednisone and dexamethasone, they can increase agitation at small doses. This is unlikely, smaller single daily doses. This is unlikely to be seen, but in a rather sensitive elderly patient, it could become problematic, especially if it's dosed later at night. The agitation could present as just the inability to sleep. Weight gain can be a side effect. Steroids are considered portmanteau drugs. If you're unfamiliar with that term, they're drugs that can be used for more than one indication, and steroids are a perfect example of a portmanteau medication because we can use them to increase appetite and therefore hopefully gain some weight in some of our patients. GI distress is a side effect. Some patients will require prophylaxis with an H2 blocker or a PPI, preferably famotidine if possible and if it's available at the time. Fluid retention, specifically with prednisone, because prednisone has mineralocorticoid activity, whereas dexamethasone has virtually none. But this is really for patients that are going to be on it long term. And plus, if you have a cardiac patient that fluid retention may be a concern, then yeah, if you're initiating something, you'd want to choose dexamethasone over prednisone. But short steroid tapers or short bursts of steroids, prednisone would be okay. You don't need to worry about long-term side effects like moon face or anything. And then again, another long-term concern would be osteoporosis. There are some topical products. The efficacy is questionable at best, but they are approved. NSAIDs, most recently, Voltaren gel diclofenac became available over the counter. Capsaicin has been, and then low-strength lidocaine is also available over the counter in many, many dosage forms. But you can get some prescription products also available topically, including patches. Okay, so we've gone through what I consider like the step one non-opioids, but for completeness of the discussion, there are some other non-opioids to bring up. These, if I had to propose, would be kind of a step 4. We certainly would not use these as a step 1 intervention. Patients would have had to fail step 2 and 3 and still be experiencing pain that's affecting their quality of life significantly to use any of these drugs. But it's worth bringing up because these are being used, that there's more literature coming out about them. People are really getting desperate with some drug shortages for things that work. So they are reaching for and learning about 2 products in particular. One is ketamine and the other is lidocaine infusion. So I just have some screenshots here of some articles that if you are interested in kind of this advanced pain management, what we use day in and day out to put patients on these regimens. So specifically, this article here was just published 9 years ago, and it was oral ketamine in the palliative care setting, and it was a case report and with favorable outcomes. There's a more recent article that came out, and though not from the US, but this is the use of oral ketamine in chronic pain management. So this is also a very good article to check out if you'd like. If you do want, I can email them to you. Just email me after the presentation and I can send them over. In terms of lidocaine, this is an article that was published, and it was a pilot study again to look at intravenous lido for opioid refractory pain, specifically in cancer patients. So again, step 4, if you will, these patients were opioid refractory at their point their stage in the disease process. And then lastly, there was a preliminary article that was published out of the eastern part of the state. And it looked at the efficacy of 5 days of continuous lidocaine infusion for the treatment of refractory complex regional pain syndrome. This was written by a physician. It was infused lidocaine for severe and/or neuropathic pain. This was actually published in the AAHPM quarterly newsletter. And there was a really good anecdotal evidence that she provided of how she is able to manage advanced stage patients with lidocaine infusion. So if we look at ketamine, and I'm happy to email any of those if you need also. If we look at ketamine can be given IV or sub-Q. So it can be pushed or it can be infused. Most people think ketamine does have to be intravenous, however, or parenteral. However, you can give it orally. It's just a compound. The cool thing about ketamine is it's super easy to compound. So it's readily dissolvable and it has great aqueous solubility. So it's like 200 to 250 milligrams per milliliter is its aqueous solubility, which is excellent for compounds. Certainly, we don't want to make it that concentrated, but in a population that may struggle with volume, that's definitely to our advantage. Personally, I've used anywhere from 10 to 50 milligrams per milliliter before, and we understandably want to start low and go slow on any kind of increasing taper with oral ketamine or IV ketamine. Ketamine's great for neuropathic pain and central sensitization. So ultimately what that means is this can actually help decrease opioid consumption, which is very important. So if you have patients on escalating doses of opioids and you don't see much additional pain relief associated with the increased opioid consumption, you could give ketamine, and that may actually allow for lower doses of opioids because they're being centrally sensitized. Oral to IV is roughly 2 to 1. So this isn't an exact science. There's not a ton of literature out there, but it's roughly 2 to 1 clinically, meaning if we needed to, if a patient was converting, this happens pretty frequently, patients in an inpatient setting and they're going home, so we need to switch them from IV ketamine to oral. If they were getting 20 milligrams 3 times a day IV, we would put them on 35 to 40 milligrams oral a day. Once again, like everything, it's always best to start low and go slow and be conservative in the approach. Not because we want patients to have breakthrough pain, but because it's much easier to repeat a dose and increase a dose than it is in patients' final days or final weeks of life to do what is referred to as snowing a patient, where they may not be fully coherent and aware of what's going on. And obviously with the potential neurologic side effects of ketamine, we want to avoid that. The half-life is short. It's roughly 1 to 3 hours. However, the residual effects and duration of action can actually be longer. So most often we're dosing ketamine 3 times a day, 3 to 4 times a day. The max time to max concentration is seen at 30 to 60 minutes orally, but it's much quicker if given IV at just 15 minutes. Ketamine is a drug that is weight-based dosing. So anytime you're doing a ketamine math recommendation, you will need to know the patient's weight. Ketamine candidates look like this. They have pain that's refractory to opioid therapy. They have refractory neuropathic pain. There are patients that are highly opioid tolerant with, again, that increased opioid consumption, or are being limited to their increased opioid dosing due to side effects or adverse drug reactions or outcomes to what they are taking. Opioid-induced neurotoxicity, we see this a lot, especially in patients that may have some kidney impairment if the opioid of choice is metabolized renally. And we're also seeing hyperalgesia for the same ketamine being used in patients that we suspect hyperalgesia for the same reason. Ketamine dosing, again, here's your weight-based dosing. A lot of times it's 0.5 milligrams per kilo if it's being given orally. The literature that's out there does recommend an initial test to be administered to evaluate the patient's tolerability of the drug. The side effects of ketamine can be limiting. This is a drug of abuse at very high unmonitored doses. Obviously, like most things, if used in a controlled environment, overseen by a care team, ideally that includes a pharmacist, ketamine can be a very safely and effectively used medications. However, it can impact vital signs. So vital signs and pain levels should be monitored at 30 and 60 minutes post the first dose. Ketamine side effects, centrally, you can see anxiety, increased delirium, vivid dreams, hallucinations, and dizziness. All of that would tell me the dose is too high. It can also increase blood pressure and increase salivary secretions. This is important because as patients progress to end of life, they already have increased secretions. However, they're of pulmonary origin, but that's actually a very disturbing side effect to families. So we do need to be aware that if there gets to the point where there are just copious secretions, it could potentially be a side effect of ketamine. And just as a side note, oral anticholinergics are not super effective at managing that. So should we prophylactically try to prevent that side effect? No. Okay, in terms of lidocaine infusion, lidocaine acts locally. It is an anesthetic. So that is unlike ketamine or most opioids. So it can be administered IV or sub-Q. If you do give it sub-Q, there is a longer time to onset, increased risk of injection site reactions. Most often, this is done in an inpatient unit. There have been some outpatients that were great lidocaine infusion candidates, and the prescribers, the physician or the attending for the patient while they're on service in their home won't entertain it just because of the risks associated with lidocaine infusion. Practitioners that are unfamiliar with it do shy away from it because obviously we all know lidocaine can have serious cardiac implications. But ultimately, what can be done and what is more common is if you can get the patient into an inpatient setting, get the infusion started. There is actually some evidence that the benefits and the relief provided by an infusion of lidocaine can actually last well beyond the time of the infusion. So like up to weeks. There's some case reports of up to weeks of increased pain relief. So in those cases, the patient would go in, receive their infusion. They kind of did it like an outpatient infusion setting. It was pretty unique and super effective for the patient. It does need to be renally and hepatically monitored. And if in patients that have liver and kidney impairment, you do need to use with caution. We're obviously titrating to effect, again, start low, go slow, and monitoring for toxicity. Also definitely explore quote unquote lidocaine allergies. A lot of times these will be from like dental procedures. Lidocaine allergies are actually very rare, and it comes down to what type of local anesthetic was administered, and not all local anesthetics have the same degree of eliciting the allergic response. So even if your patient did have an allergy to a local anesthetic, they may still be able to tolerate lidocaine. Okay, what does a lidocaine infusion candidate look like? They also have opioid refractory pain if they need quick relief, so less than 1 hour to onset of pain relief compared to oral options. An infusion of lidocaine may be appropriate, of course, if they're in a care setting that can support that. If they need long-acting pain relief, so as long as 10 days after a dose, remember I said there was that case report, it lasted like weeks, but there's much more evidence that says these doses, single infusions, can provide relief after as long as 10 days of a dose. And then frequent use of PRN opioids for breakthrough pain. So if somebody's reaching for their breakthrough pain opioid 4+ times a day, this could also be a potential solution for them, again, in the right care setting. This is a dosing strategy. I'm not going to read this to you. However, it's important here to monitor for appropriate therapeutic levels. So they're listed there for you. And then I am going to read this. After a bolus injection or continuous administration for up to 12 hours, the half-life increases, and it does show linear pharmacokinetics. So it's super predictable in that case, which is great. Dosing strategies, these are some additional ones. So in patients, because remember, there's not guidelines here. There's not a ton of evidence out there. So these are what is in the case studies and case reports and have started to be reported on. So if patients are not appropriate for a continuous infusion, you can do a bolus dose over 20 minutes, and then an additional dose 1 hour after that. This is also super effective in getting patients home from an inpatient setting and keeping them comfortable during transport. In patients that do have good response to continuous infusion, you can use bolus doses to titrate down and determine how long those boluses are going to be effective for the patients. There are some other documented dosing strategies that are weight-based listed here. And just a last note that single doses up to 5 to 10 milligrams per kilo have been used in protocols for extreme pain. That's most often in an inpatient setting. Side effects of lidocaine, it's very common for lightheadedness, numbness in the back of their mouth, GI disturbances, dizziness, and or sedation. Just a side note here, I said you're gonna have to monitor for therapeutic plasma levels. Greater than 6 is considered to be toxic. And what toxic looks like are last symptoms. So again, extreme numbness in the back, hypotension, this stands for a local anesthetic. Systemic toxicity. And how it presents again is that consistent numbness in the back of their mouth, hypotension, metallic taste and ringing, visual and audio disturbances, nausea, dizziness, and drowsiness. Infusion monitoring, I've mentioned a couple times. Because of the cardiac implications, it would be worthwhile to do an EKG, even if they were outpatient, within 14 days of the procedure. If male greater than 65 years old or a female greater than 55 years old, or if we know they have cardiac problems. If clinically indicated, you can also get some potassium, ALT, and bilirubin levels and repeat the EKG. Blood work ongoing should include that potassium level, the creatinine, LFTs, and bilirubins. During each treatment, we're going to want to monitor for blood pressure and heart rate. This is similar to the ketamine dosing. Pain levels every 15 minutes during infusion and every 15 minutes after the infusion for 2 questions. Okay, so now that we have graduated and gone through our non-opioids, now we are going to get into opioids. So opioids are present at step 2 and step 3 of the WHO pain ladder. So we've graduated, or our pain is not being relieved enough from non-opioid plus or with or without an adjuvant. There's still increasing or persistent pain. So now we're going to introduce an opioid for mild to moderate pain with or without those adjuvants and non-opioids. And then once we escalate to step 3, this would be opioids for moderate to severe pain, again, with or without those adjuvants. Okay, so opioid types are important before we really dive in here. The first type of, I guess they're kind of categories. They're the easiest way to explain it. First is pure opioids. So codeine, morphine, those are pure opioids. Semi-synthetic, they're made in a lab, right? So we have anything that starts with oxy or hydro is a semi-synthetic. It's one step away from a pure opioid. And then we have our fully synthetic. They bind to opioid receptor types, but they are receptor sites, but they are not of the same physical structure as the pure and semi-synthetic. So those are our fentanyls, our methadones, our tramadols, our Nucyntas of the world. This is also important when it comes down to drug allergies too. If a patient, for example, had a reaction to tramadol in the past, we wouldn't necessarily have to hesitate. Of course, if it was anaphylaxis, we would want to explore it a little more, but it certainly would not preclude the use of like morphine, for which we will learn is our gold standard, for example, especially in end-of-life care or palliative care. Okay, so opioids are effective for both nociceptive pain and neuropathic pain. So sometimes I've heard out there like, oh, you don't give opioids for neuropathic pain, but that's wrong. Some opioids happen to be better at managing neuropathic pain than other opioids. For example, methadone is known as a drug that's good. It's better at treating neuropathic pain, but all opioids are effective for both nociceptive and neuropathic pain. Again, opioids are step 2 on the ladder. So here we're really talking about codeine, combo opioid products like Percocet and Norco, again, with or without the adjuvant and the non-opioid. Step 3 would be morphine, fentanyl, oxycodone, methadone, and again, with or without adjuvants and non-opioids. This is where we would introduce long-acting scheduled doses and perhaps get a little bit more creative in our approach. All right, so morphine, as I mentioned, is our gold standard. Oral to IV is 3-to-1 clinically. I've seen 2-to-1 recently, but clinically it's 3-to-1. It's metabolized in the liver, but it's renally excreted, and that is very important because as our patients age, their kidney status can decline, and morphine actually has 2 active metabolites that will accumulate and present as agitation or confusion in renal failure. That being said, those metabolites take time to accumulate. If a patient does have less than 1 week roughly of life left to live, we will still proceed. You can still proceed with using morphine. There's peak relief provided in 60 minutes, but Q4 dosing is appropriate for Q4 hour dosing is appropriate for breakthrough pain because the duration of action is roughly 4 hours. And it can be administered by virtually any route. So when I said we sometimes need to get creative, we can be very creative with morphine because it is very well absorbed from most routes of administration. Codeine actually undergoes metabolism to become morphine. It's generally not a preferred drug. It increases the risk. There's a greater side effect prevalence of constipation, which is not something we're trying to accomplish for sure. It's not going to be effective in patients that lack the required CYP enzyme for that conversion. That's probably not something you're going to know, but it's something you could find out if a patient with increasing doses is reporting there's no additional pain relief. Oral codeine to oral morphine is 6-to-1. So it's 6 times less potent than morphine. Hydrocodone is metabolized to hydromorphone. There is a single entity product on the market called Zohydro. There was a lot of opposition when Zohydro was approved by the FDA about 4 or 5 years ago now. Lot of groups of kind of opioid patient advocates did not think that we needed another single formulation opioid on the market, but it did get approved. It is supposed to be abuse deterrent. So that is out there for you. Hydrocodone is, of course, most commonly used in combination with acetaminophen, and some of our patients will refer to it as still as Lortab or Vicodin. Oral hydrocodone to oral morphine clinically is approximately 1-to-1. So if we do have patients that are on one, we will just convert on a 1-to-1 basis to the other one, and then we can always adjust if needed. Remember, the very beginning of our presentation, I said pain management is as much an art as it is a science. So this is a good example of that. Hydromorphone. Hydromorphone, we need to reduce initial doses in moderate to severe liver impairment. So this is important because hydromorphone is so potent that we're already starting at what feels like very low doses. So if their liver is impaired, we need to adjust the dose. And we also need to reduce the initial dose if they have creatinine clearance less than 60 mils per minute. So if they have chronic kidney disease. Oral hydromorphone to morphine is 1 to 4, meaning morphine is 4 times less potent than hydromorphone. So again, it is very potent. And then IV hydromorphone, that ratio goes to 1.5 to 10, meaning you would need 10 times the amount of morphine to get a dose of the equivalent dose of hydromorphone. Oxycodone is actually metabolized to a very small extent to oxymorphone by your liver. Oxycontin is available as a single entity formulation. Again, we most commonly are seeing this used in combination with acetaminophen. Patients will refer to this as Percocet. It is only perceived as more effective than morphine. It sometimes makes patients feel better because of the delta receptor that it binds to. But clinically, it would be safe to use 1 to 1 as a conversion, but technically it is oxycodone is 1 to morphine's 1.2 to 1.5, meaning that it's a little bit, because it's perceived as more effective or a stronger opioid, if you will, you would need to have an increased dose of morphine than just 1 to 1 to do equivalence. In patients with renal impairment, oxycodone is preferred. Oxymorphone has virtually no active metabolites. Opana is the brand name drug that we're familiar with. It's the single entity extended release formulation. PO oxymorphone to PO morphine is 1 to 3, so it's 3 times more potent than morphine. It's contraindicated in moderate to severe liver impairment. Not much oxymorphone being used simply because oxycodone would be preferred. Fentanyl, we all know, has significant first pass metabolism, which is why we do not give it orally that often, though there are some creative formulations coming to market, like fentanyl lollipops. I think everyone's seen that episode of Intervention. Fentanyl is not for opioid naive patients. Patches are the most common dosage form. These patches are not appropriate for cachectic patients. It's not easy to titrate fentanyl, and they take 12 hours to turn on and 12 hours to turn off. So when you put a fentanyl patch on, your patient's not going to have the level of relief they're going to experience for 12 hours. And if they have an adverse drug reaction to it and you take it off, it's going to take 12 hours for what is in their skin to get absorbed and be eliminated. So keep that in mind too. Fentanyl patches definitely have their place in a pain patient's plan of care if it's appropriate. Also be aware that there are some in-between strengths, if you will, out there of fentanyl patches, and not all insurers will pay for those. Fentanyl patches need dose based on an equivalence chart. So looking at what the patient is on of whatever drug they're on, whatever oral medication or IV medication, you would find the corresponding patch strength. And this is from the manufacturer that's provided. Tramadol has a lower affinity for opioid receptors than even codeine. Remember, codeine was 6 times less potent than morphine. Tramadol has even less efficacy than that. Tramadol is kind of like a dirty drug in pain management. It's definitely falling out of preference. However, there's less respiratory depression associated and less addiction potential associated with tramadol, though it definitely is still a drug people could ultimately end up seeking. The half-life for immediate release tabs is approximately 7 hours. It is available as an extended release formulation. Max daily dose is not to exceed 400 milligrams a day. It does need to be used with caution in patients with liver impairment. And of note, it lowers the seizure threshold, which is why I said it's kind of a dirty opioid. And it also inhibits the reuptake of serotonin and norepinephrine, which can increase the risk of side effects and obviously drug interactions of commonly used medications. Okay, methadone is increasingly being seen for use with pain management, especially in the hospice and palliative care setting. So it's an excellent choice for neuropathic pain. It's one of the best opioids for neuropathic pain. It does accumulate with repeated dosing. This actually deters some prescribers that are unfamiliar with it because it can be dangerous because of that. However, it is completely safe when it's dosed appropriately, and a methadone safe use protocol is being employed. It's very well absorbed orally. It's actually very well absorbed from most routes of administration. It can be virtually administered by, it can be administered by virtually any routes. It's available as tabs. It's available as an oral solution. The oral solution, it comes in a 5x5, so a 1x1, or a 10x1 oral concentrated solution, which is helpful for patients that can't swallow. It is available as an injection. It's a multi-dose vial. It's an expensive multi-dose vial. And it goes in and out of back order often. So we don't often see patients being put on methadone injection. Some patients will come to us on it, and that's fine. We can continue that. But because of its excellent oral bioavailability, a lot of times we just put patients on oral, even if we have to do the oral solution. The half-life is anywhere from 8 to 150 hours, which is perfect because we don't need a special formulation for it to be long-acting. It is inherently long-acting. So even if we're crushing it, which we need to do sometimes in our patients that can't swallow, it will still preserve that long. It binds very tightly and releases very slowly from opioid receptors. So it is inherently long-acting. When starting a patient on methadone, you do need to ask yourself 3 questions. First is, does the patient smoke? Second is the patient overweight? And third is, does the patient have a history of arrhythmia? Because smoking increases the metabolism of methadone, which means your patients that are smokers are going to reach steady state faster. They may need more frequent doses. So maybe in those patients, if they're going to continue smoking, they will need to, first of all, consistently smoke. If they stop smoking, they risk accumulating more methadone because they're going to be metabolizing it slower. But those patients may also need to be on methadone 3 times a day, as opposed to a non-smoker could potentially be just using it twice a day. Methadone is stored in adipose tissue. So in patients with excess adipose tissue, it has an increased half-life, which means it's going to take those patients longer to reach steady state. 3, methadone should be used with caution with patients with documented history of arrhythmia. This is a risk. It's a very real risk of QT prolongation. However, my eyes don't really open or get concerned about this until patients exceed 50 milligrams per day. If they're on other drugs that also prolong the QT interval, which admittedly a lot of drugs used for symptom management do have the potential to do so. But in the literature, it's QT prolongation due to methadone as seen at doses, total daily doses greater than 100 milligrams. Methadone is initiated via a taper. Methadone check should occur daily for the first 5 days, then as appropriate. A methadone check can be a pharmacist or a nurse calling and checking on the patient, asking about their degree of pain relief or their level of hopefully increasing level of comfort, asking them what time of day they're taking their medicine, making sure they're taking it as it's been outlined for them. And this is most often referred to as a methadone safe use protocol. It is necessary to taper off of other opioids if you're rotating to methadone, because as methadone is going to take time to accumulate and reach steady state, roughly 3 to 5 days for that to occur. We don't want the patient to go without opioids and end up in a pain crisis. Methadone conversions are based on ratios, so this is not just straight math. So please make sure you're converting to the total daily dose of oral morphine. This should say oral here, oral morphine equivalent, OME. And then you convert based on these ratios here. We have had patients that were on just extreme doses of oral morphine equivalent in 24 hours. And then understandably, we will also need to increase the ratio. But that again, because there's not much literature on extreme situations like that, you really need to use best practice in that case. But we've divided divided by as much as 30 or 35 from the oral morphine dose to get our target methadone dose for some patients. There are some additional ways to dose methadone. They've definitely fallen out of practice and are not common. Some prescribers that may be more old school, or it was the way they did it in medical school, will prefer this. So the Morley-Macon method is the one that I've seen used before. This is when you actually take the total daily dose of morphine and take 10% of that, and then you give that dose every 3 hours as needed for 5 days. Then you're going to take the average of on days 4 and 5 of what their requirement was. So how much were they still required to be taking on days 4 and 5? And then that is what you would use as their dose. This is super outdated. It relies heavily on good, accurate record keeping, which we all know is very difficult at times. So if you are going to do this, please write out everything for your patients so they don't need to invent their own tracking mechanism. There's also a Friedman method. It takes the patient's age into account. This is a slippery slope, especially when we're talking about palliative care or patients with serious illnesses. It can ultimately end up underdosing a patient. Okay, buprenorphine is another opioid we'll discuss that's definitely kind of in the spotlight along with lidocaine and ketamine currently, just because people are kind of getting desperate for non basically Schedule II substances to use. So buprenorphine is a Schedule III. It's mixed opioid agonist and antagonist. It's partial mu agonist, kappa antagonist, and delta agonist, which all comes into effect in its role in pain management. So it is also inherently long acting at receptors. It lasts for 24 to 60 hours. It has very poor oral bioavailability. So it is available as a sublingual tablet, so it will absorb sublingually. You can give it as a patch, an implant, dissolving film on the patient's cheek. You can give it as an injection. You can actually give it as a long-acting injection. It's available as a combo with naloxone. We're all familiar with Suboxone. That's available in a film and a tablet. It does not require a quote unquote X number for dispensing it for a pain indication. This is huge. And unfortunately, I have come across a number of pharmacists that are not aware of this. Some unfortunate situations that patients have been, or prescribers have been called, or patients have been turned away for filling buprenorphine prescriptions because they just unknowingly said, no, I can't fill this. I don't have the appropriate credentials listed on this prescription. If the indication says pain, then you actually don't need the X number. That is for substance use disorder only. Buprenorphine is effective for both nociceptive and neuropathic pain, like the other opioids we've talked about, including methadone. It is safer in the elderly and renally impaired, so it is a good option in our elderly patients. And it also has a better adverse drug reaction profile than other options. So buprenorphine in hospice and palliative care, why would we consider using a drug that most commonly is used for substance use disorder in this population? So first, it's effective for pain. And we've already established that pain is super common and it's super prevalent in our populations. Interdisciplinary team involvement, which is really great because it's required for buprenorphine appropriate use. And a palliative care team is in nature interdisciplinary. Palliative care also looks at a whole person concept. So we can manage both palliative care and hospice disease states as well as addiction. So instead of just treating the patient for their addiction or just treating the patient for their pain, we don't work in silos in hospice and palliative care. It is very much a whole person approach. And we are unfortunately experiencing, and everyone needs to be aware that we are only going to continue experiencing an increasing number of patients come on hospice and palliative care services and need hospice and palliative care inputs that may have a history of substance use disorder. I did want to address also, there's this concept of the ceiling effect with buprenorphine. This is theoretical in nature, and it's saying that there's a ceiling effect on respiratory depression and that there is a lower risk of death from respiratory depression. This is controversial. You also need to keep in mind that most patients are not just on buprenorphine in our setting. Most patients in the hospice and palliative care setting are on some other opioids also, even if they're just using them for breakthrough pain, which they can safely do, even though it's a partial antagonist. But it's unlikely that there's a ceiling effect on analgesia. So just keep that in mind also. Okay, what does a buprenorphine candidate look like? Somebody that has moderate to severe pain, somebody that's not requiring a ton of oral morphine equivalent in a day, somebody that cannot tolerate other opioids, has a history of substance use disorder, and if they are or their family is a potential for abuse risk and diversion risk, this would be a good option for them. You should probably avoid using buprenorphine for patients that have extremely severe pain. If they have a very high daily opioid consumption requirement, if they've recently used a full agonist, so MS Cotton, fentanyl patches, etc. If they have severe liver impairment, or if they have a prolonged QT interval. Okay, so to initiate opioids in an opioid naive patient. So this is kind of blurring the lines with our fifth objective, which is how the pharmacist's role in pain management. So the pharmacist's role in pain management is really relevant throughout this whole presentation, but specifically what we are talking about now too, without being formally announced here, this is something that a pharmacist would absolutely be called on to do. We encourage with all of our organizations that we work with nationwide, we encourage them that anytime the word drug or medication, and certainly anytime opioids are being discussed, to involve a conversation, the pharmacist in that conversation, so we can make sure it's being done appropriately and safely. So to initiate opioids, so this would be in an opioid naive patient, or step 2 on the WHO pain ladder. We're going to start low and use the lowest effective dose. We all know that. We're always going to start with immediate release formulations, and we're always going to dose them PRN. So we are not out of the gate going to schedule any opioids for the patient. ER formulations can be initiated once you have a good idea and there's record keeping and documentation of how much PRN use is being used of the PRN opioid. And please investigate all allergies to opioids. Remember, when we first started talking about opioids, I categorized them as pure, semi-synthetic, and synthetic. We all know that people think they're allergic to things, and we all know that there are side effects. And certainly we need to educate them on side effects versus allergies in a respectful way. But also the care team should be on them. It should be on all of us to educate in a way that they understand, because we don't want to automatically deter or limit our options for what we can use, especially when a lot of times we do only have certain things available to us in our toolkit. Okay, so an example of initiating opioid therapy in a patient. So this is our patient. We're going to follow for a couple cases. So patient KP has chronic back pain from a previous injury. He has been using naproxen 500 twice a day and over-the-counter Aspercreme patches. They're a 4% patch, as a side note, 4% lidocaine patches. Pain is increasingly worse at night. He rates it a 6 to 7 out of 10. It does prevent him from sleeping, and his activities of daily living are starting to be affected. At best, his pain is a 4 out of 10. His doctor is requesting a consult, asking if MS Cotton 15 milligrams twice a day would be appropriate. That is the lowest that MS Cotton comes. So extended release morphine tablets, 15 milligrams. He has no known drug allergies, and his kidneys and liver are fine. So would MS Cotton 15 milligrams be appropriate for KP? You can think about that to yourself for a minute. Okay, so I hope you came up with a very quick and resounding no. MS Cotton 15 BID for an opioid naive patient is not appropriate because it is an extended release formulation. So this patient is not on any opioids, so he is at step 1 currently. He's taking, he's using a non-opioid with an adjuvant, the lidocaine patches. And step 2 is immediate release opioids dosed PRN. So a more appropriate order for KP would be hydrocodone, acetaminophen, 5-325 every 4 to 6 hours as needed for pain. Okay, so once we do have a patient on an opioid, let's talk about opioid dose adjustment. So patients that are already tolerant to opioids. So this is important that a pharmacist be involved also, because we need to calculate the total daily dose of all scheduled and PRN orders. So if KP got to the point where he was taking some Norco scheduled and PRN, we would need to ask him about his, his record. We would need to rely on his record keeping to ask, how much he's been using. Sometimes, especially if a nurse is involved or a caregiver, they will say, oh, well, they take between 3 and 4 tablets a day or 3 and 5 tablets a day. Or we'll be told, first we should say, if you do have somebody give you a range like that, please always use the lower end of the range, first of all. Second of all, if you have a situation where maybe they say over the weekend, maybe it's Monday, and they say, well, over the weekend, he needed 70 milligrams of morphine. If they are unable to tell you, what if 20 of that was on Saturday and 50 of it was on Sunday? Okay, that's obviously a huge difference, and the pain has escalated very greatly in a short amount of time. So instead of just assuming 35, using 35 milligrams as an average, we definitely want to explore to make sure we're doing the math based on the most appropriate and most realistic situation. Okay, so after we calculate the total daily dose of all around the clock and PRN opioid doses, we need to convert them all to the same opioid. So if for some reason crazy things happen sometimes, if they've been using dilaudid PRN and oxycodone PRN, and maybe they're on a fentanyl patch too, you need to convert them all to the same opioid. Most commonly, this is oral morphine equivalent. Most PDMP reports will report in terms of oral morphine equivalent also. Once you have that, add the totals together and then determine the new schedule based on drug formulation and patient parameters. So here's our example for our patient KP. It's been 6 months since our first consult. The doctor did take your previous recs, and based on the usage after 3 months, he ultimately ended up initiating MS Cotton 15 just at bedtime. So he was routinely taking at least 3 doses is what we can assume from that, because he's now 3 doses of that Norco 5. So now he's on MS Cotton 15 at bedtime. He is still requiring 3 to 4 doses of Norco 5 daily to continue his job as a tennis instructor, but it feels burdened by having to take so many tablets, and he often tries to hold off, which ultimately is resulting in more pain. KP states when he doesn't take his Norco, his back sometimes burns in pain. The doctor is asking where to go from here. So just think to yourself what you might do to help manage this patient's pain at this point. Okay, so here is where what our notes should be jotted down. So our patient's taking 3 to 4 tablets of Norco 5 throughout the day, which does warrant an increase in his dose of MS Cotton. So if we're assuming 3 to 4 doses a day of Norco, that's 15 to 20 milligrams of hydrocodone. 15 to 20 milligrams of hydrocodone clinically is 1-to-1, so 15 to 20 milligrams of oral morphine. So this one's pretty straightforward. At a range of 15 to 20 milligrams additional morphine that's required, we could easily, based on what's available, increase his MS Cotton order from 15 at bedtime to 15 twice a day. We will want to continue his Norco as ordered for breakthrough pain. Another rule of thumb is that we're only going to increase or change one thing at a time. If you're changing more than one thing at a time and it's not effective, you're not sure what's not effective, maybe one is increasing in efficacy and the other one's not. So we only want to change one thing at a time for a patient. You could consider adding gabapentin 100 for neuropathic pain if the increase in MS cotton doesn't resolve that transient burning. Remember, he was holding off, he was chasing pain instead of treating it. Opioids are, including morphine, it does have the potential to treat neuropathic pain, but that's definitely something we always like to have, like something in our back pocket if you think about it that way. So you can initiate the MS cotton or an increase to the MS cotton 15 BID, but keep in your back pocket a plan for if that relieves his pain, but he still has some pain, some burning that he's experiencing, you may want to consider adding gabapentin in the future. Okay, so opioid rotation. So when we're rotating from opioid to opioid, once a patient is on an established opioid regimen, we do need to account for incomplete cross tolerance. So what that means is that if our bodies become tolerant to the opioid that we're taking. And if we're going to switch that to a different opioid, while it's binding the same receptors and mainly the same way, just a little bit different or a little, maybe a little bit tighter, or a little less tight of a bind, but your body is not going to recognize a new opioid to that full extent. Okay, so if we're switching from one opioid to another to account for that incomplete cross tolerance, your body's like, I know something like you has been here before, but you're not quite that same something. Okay, so I know how to respond to you, but I'm not going to respond to you that much, to that extent. Because of that, we need to reduce our dose by 25%. Okay, if not, we could potentially end up overdosing our patient. Some patients do have a better response from one opioid to another, which warrants opioid rotation. So that's when equianalgesic dosing charts come into play. So this is a super basic equianalgesic dosing chart. Please make sure you're vetting any equianalgesic dosing chart that you're using. The one I use all day, every day is in the book by Marilyn McPherson, Demystifying Opioid Conversions. It always sits on my desk with me. And there's a really nice chart right on the inside. And it's an ASHP publication. There is a newer version of it also. With some additional chapters. But that being said, please make sure, like Googling equianalgesic dosing charts, a little bit risky. We all know that. But if there are some really good, valid ones out there, and Pharmacy Times has one also that you can reference. Okay, so here's our opioid rotation example. Patient AR is using OxyContin 40 milligrams twice a day and Percocet 10 every 4 to 6 as needed, and dexamethasone 4 milligrams every morning for pain secondary to her metastatic malignancy. She uses anywhere from 2 to 4 Percocet tabs in 24 hours. She does have a comorbidity of dementia and is presenting with mild dysphagia. Doctor wants to know about a pain patch. Her pain is well controlled on her current regimen. The oncologist would like a recommendation for a topical opioid and a new drug for breakthrough pain. She has no known drug allergies. She does have CKD2, no hepatic impairment. She weighs 82 kilos. So think about that for a minute. Doctor's wanting a pain patch, he said. And he also asked for a new drug for breakthrough pain. Okay, so here we have OxyContin 40 milligrams twice a day, which means the patient is taking 80 milligrams of oral oxy in 24 hours. Percocet 10 325, we said she was using 2 to 4 doses a day. Remember, I said we're going to go on the conservative end of that so we don't increase the risk of adverse negative drug outcomes. So we'll say 2 doses a day is an additional 20 milligrams of oxycodone a day. 80 plus 20 is 100 milligrams of oxycodone. We're going to reduce by 25% because we need to switch to a different opioid. Oxycodone is not available as a quote unquote pain patch. So in this case, we're going to do our math on 65 milligrams of oral oxycodone. The patient did weigh 80 plus kilos. So they do have enough, it can be assumed they have enough adipose tissue to support the use of a transdermal fentanyl patch. So here we're going to refer to our chart that we saw before. So the oxycodone requirement is 75 milligrams of oral oxycodone, which puts the patient actually in this range, the 67.5 to 112 range, which means the patient should be using a 50 mic fentanyl patch. There's an error on this slide there. Okay, so our recommendation for opioid rotation, we're going to initiate a fentanyl 50 mic patch Q72 hours. We can give the last dose, actually these arrows are just wrong. The math is right, but the arrows are in the wrong place. We're going to give the last dose of OxyContin when the first patch is applied. And it's okay to crush the dexamethasone tablets. Remember that the patient was experiencing difficulty swallowing. It's called dysphagia. So it's okay to crush that tablets, or you can use the dexamethasone 1 milligram per ml oral liquid. You can DC Percocet tablets and initiate oxycodone 10 milligram tablets. So you're probably thinking 5 minutes ago, Michelle, you told us we're not going to switch more than one thing at a time. Well, we're changing from Percocet, which was oxycodone acetaminophen, to just plain oxycodone. The patient can certainly supplement with acetaminophen if they need to, but it's really not a change because it's oxycodone to oxycodone. So oxycodone 10 milligram tabs every 4 to 6 hours. That's the same dose and the same dosing regimen. Those can be crushed, or you can use oxycodone 20 per 1 oral solution. And at that concentration, the dose would be 0.5 milliliters, which is 10 milligrams every 4 to 6 hours as needed for breakthrough pain. Side note, oxycodone oral solution is a little bit cost prohibitive depending on who the payer is. So keep that in mind too. It is generically available, but there's not many manufacturers in the marketplace. And I've seen a 1 ounce, 30 milliliter bottle cost upwards of $150 before. Okay, patient BC has never had adequate pain relief. We're going to talk about methadone now. Patient BC has never had adequate pain relief since being diagnosed with stage 2 breast cancer 9 months ago, but she always just deals with it. It is starting to affect her well-being, however, and the doctor consults with pharmacy to determine if the patient would be appropriate for methadone. The pain is described as generalized, and after she stands for greater than 20 minutes, her legs burn and feel numb, which is a side effect of her chemotherapy. She is currently using morphine ER 30 milligrams 3 times a day, so MS Cotton 30 milligrams 3 times a day, and hydromorphone 4 Q4 PRN. She's used 5 doses of hydromorphone in the last 24 hours. She is a smoker. She's allergic to Keflex and IV contrast dye. She's 5'3", 62 kilos. She has hypothyroidism and GERD. So we are going to convert this patient to methadone based on her current MS Cotton and hydromorphone utilization. So you can think about that for a minute. Okay, so she's using morphine ER 30 milligram tablets 3 times a day, which is 90 milligram oral morphine equivalent. Hydromorphone 4 times 5 doses, 4 milligrams times 5 doses a day, is a 20 milligrams oral hydromorphone a day. 20 milligrams of hydromorphone a day is rough, so it's a 4-to-1 ratio. So we would refer to our conversion chart, and it's a 4-to-1 ratio, so that's roughly 80 milligrams of oral morphine equivalent a day. So we have our 90 from our MS Cotton, our 80 morphine equivalent from our hydromorphone. So 90 plus 80 is 170 milligrams of total daily dose of oral morphine, roughly. So 170 total daily morphine equivalent minus 25% for incomplete cross tolerance is 127 milligrams of morphine, roughly, in a day, a daily requirement. The methadone conversion ratio, since methadone's all converted via ratio, puts us at 8-to-1. Okay, so we're going to take 127 milligrams of oral morphine equivalent divided by 8 gives us 15.87 milligrams of methadone. Because of this, our target is going to be 5 milligrams 3 times a day. So knowing that methadone is available in a 5 milligram tab, a 10 milligram tab, or an oral solution, we can do 5 milligrams 3 times a day very easily with our target daily dose of 15 milligrams. Also, she would be most appropriate for 3 times a day dosing because she is a smoker. We cannot start off right out of the gates by dosing her 3 times a day, because remember, you always have to initiate methadone via a taper, because it's going to accumulate over roughly 3 to 5 days to reach steady state. So day 1, we can give methadone 5 milligrams at bedtime. Some very elderly patients will actually start more conservative with that if they report being like ultra sensitive to medication. But in this case, it will be fine to initiate methadone 5 milligrams at bedtime. We're going to give the MS Cotton as ordered, no changes. On day 2, we'll start methadone 5 milligrams twice a day. We will just give the MS Cotton 30 milligrams twice a day, no longer 3 times a day. So we drop that down to BID dosing. On day 3, we're going to give methadone 5 milligrams 3 times a day. This is what we think her target dose is going to be. We'll give the MS Cotton 30 milligrams in the morning. That will be her last dose of MS Cotton, and then we will DC that. We're going to continue hydromorphone tablets every 4 hours as needed for breakthrough pain, because we don't want to change too much at once. Okay, so we're stopping tapering off of the MS Cotton, tapering up on the methadone to get us at our target dose. We're not going to change the drug for breakthrough pain at the same time. At this point, she knows when she takes a tablet of hydromorphone, the level of pain relief she can expect. So we don't want to alter that at this point. All right, just a little slide here on using opioids via the IV and subcutaneous routes. The bioavailability for IV and subcu route is 100%, as we all know. Okay, so we don't need to worry about any first pass metabolism. The bioavailability of oral is not, because of first pass metabolism. If we don't account for this change in bioavailability, our patients are going to end up overdosed. So when we're converting patients from oral to IV or sub-Q, this often happens for infusion reasons, we're going to calculate the total daily dose of oral opioids in terms of morphine equivalent. Remember, morphine's our gold standard. We're going to convert to IV morphine equivalent. So at that point, we're just converting oral morphine to IV morphine. We're going to then convert that to our drug of choice. So whether it needs to be IV dilaudid, or if it's going to say IV morphine, you would select your drug of choice. At that point, you're going to stop what you're doing. You're going to divide the dose by 50% to get your total daily target dose. At that point, your total daily target dose needs divided by 24 hours to get what your basal rate should be if using a pump. Please be mindful that dilaudid, since it is so much more potent IV, parenterally than morphine, that very small doses may not be able to be measured by pumps. So morphine may be more appropriate based on what your patient's oral morphine, daily morphine requirement is. Then, of course, after we have a basal rate, we need to calculate the PRN or demand dose, and this is often 50% of the hourly rate, dosed every 15 minutes. I've seen every 20 minutes before too. It normally depends on the physician's preference, and that can be via PCA or clinician-administered bolus. Okay, opioid side effects of all opioids to be aware of. Constipation, you're never going to not experience constipation. It's not a side effect we become tolerant to. It can also cause nausea and pruritus, and of course, sedation. To minimize and alleviate side effects, gradually titrate the doses to efficacy. Choose a more appropriate route of administration. If one route of administration is causing significant side effects, maybe, for example, IV is causing increased sedation, you could switch to oral, or oral may be causing increased nausea. Switching to another opioid is always a problem. You can add is always an option, not a problem. You can add an adjuvant so the dose can be reduced, such as, again, we talked about ketamine being one of them. And the hand that writes the opioid prescription should also be writing the laxative prescription. So Senna, with or without Docusate, there's a lot of controversy about Docusate right now. So with Senna, at a minimum, we need a stimulant laxative on board. That can be initiated as PRN. Most patients, as they really require increased around-the-clock opioids, do need to be on something scheduled. Okay, so we have just spent probably the last 25 minutes talking about what the pharmacist role is, because we were doing what we can always be doing. But to kind of more define what the pharmacist role is, we can go over these points. So pharmacists can assess the patient as a member of the interdisciplinary team. So most palliative care teams do identify pharmacists as an integral member of their interdisciplinary team. I am actually on a palliative care interdisciplinary team. It's called a Project Echo. And we have a nurse practitioner, a social worker, a physician, and then I'm the pharmacist representative. So of the 4 members of that interdisciplinary team, a pharmacist is one of them, which is super exciting. We can help calculate equianalgesic doses. We always say, we'll do this for you, we'll do this with you, we'll check your work, we'll teach you how to do it. Pharmacists are the best people to be teaching people how to do that, other healthcare providers how to do that. We can consult with the prescriber on dose changes and opioid rotation. We can counsel patients when prescriptions are filled. I recently watched a TED Talk, and it was about addiction, and it was a patient that had been in a motorcycle accident, and he had said that he was never counseled by anyone on prescriptions. And while the word pharmacist was never brought up in the whole TED Talk, I was a little bit admittedly disappointed to hear that, because I felt like that was a missed opportunity that a pharmacist had to really impact this patient that ultimately ended up addicted to opioids and was fortunately alive to talk about his experience and is in recovery. We can follow up with the patient as therapy continues, just as part of ongoing monitoring, including methadone safe use protocols. So remember, a methadone safe use protocol should have 5 days of at least 5 days daily for 5 days, checking in with the patient. There's no reason a pharmacist can't fulfill that obligation to the patient. We can also monitor for adverse drug reactions and side effects. Ultimately, our treatment goals collectively as a care team, including the pharmacist, need to be to prevent, reduce, or eliminate pain for our patients. Patients should be helping in setting their goals, and their goals need to be realistic. If a patient is an end-stage cancer patient and says they want their goal to be freedom from pain, I want to be at a 0 or a 1, we as a care team need to help that patient set more realistic goals for them. That's probably not going to happen as a result of just one conversation, but that certainly needs to be a work in progress. We can, again, meet the patient and their caregiver with where they are and their level of understanding of pain and pain management and the drugs we're using to manage their pain. But again, a lot of times questioning, and we should be listening more than we're talking, and really letting them, exploring with the patient, what is the minimum level of pain that is realistic for you to still enjoy life and get quality out of life. Which is our goal, to improve quality of life, increase or help our patients regain independence, and ultimately increase their functional capacity. So again, I'm going to leave you with, patients do have rights when it comes to pain management. It's the right drug. We just went over most of the drugs you will see used for pain management, the right dose, the right route of administration, and the right timing. And if you have any questions, these are the information how you can reach me. And of course, I have my citations for you also after this, which are all of the things that all of the sources I use day in and day out. Also, I need to mention that in order to get CE for this presentation, you have to complete the survey at the link, which is on the Whova app also by March 11th. Thank you, everyone.